Hey everyone, welcome to another episode of What the Dementia by Bambu Care. I'm your host, Brianna Wilson. I'm a certified dementia practitioner and the founder of Bambu Care. So today is a super important topic, hospital stays and dementia. Now, because this is such a dense topic, we are going to focus in on delirium because this is a big issue when it comes to hospital stays, especially for people with dementia. Before we get started, if you like the What the Dementia podcast, please be sure to give us a good rating to help other dementia care partners find our podcast. It really does help Bambu Care and the What the Dementia podcast reach more people who need this type of information. And if you would like to keep up with us between episodes, consider following us on Instagram at Let's Bambu or joining us in our free support community at letsbambu.com/champions, okay? So let's go ahead and get started. So if you aren't familiar with what delirium is, it's an acute disturbance in attention, awareness, and cognition, which can subsequently impact behavior. And so it's basically a rapid change in mental status and even functional performance. It will usually happen over the course of a few hours or a few days, and the symptoms you notice can fluctuate. But overall, you can tell that something is off about the person. They aren't their normal selves. They have deviated away from their normal baseline, okay? Now, the most important thing to understand about delirium is that it's considered a medical emergency. Why? Because it means that something is going on medically or metabolically with the person, and it's usually the first and sometimes only sign of an underlying illness in people who are older and people who have dementia. So it could be a urinary tract infection, pneumonia, sepsis, out of whack vitamins, minerals, electrolytes, or blood sugar levels, hypoxia even, a number of things. So, if you notice changes such as your partner having more trouble than usual concentrating, or when they talk, they aren't making a lot of sense, or they're saying things that are a bit bizarre, or if they're having trouble sleeping and they're restless or becoming more agitated than usual, or on the flip side, if they are unusually sleepy or more confused and disoriented than usual, if they are more moody than usual, or are experiencing delusions like paranoid beliefs and even hallucinations, which are usually visual hallucinations but can also be tactile and auditory hallucinations as well. If you notice any of these changes, it's best to call the doctor or get them to the hospital for assessment. And let me just say this, if you call the doctor or nurse and they just blow off the changes as just the dementia, you know your person. If something doesn't feel right, still get them to the hospital for assessment, please, okay? Now, delirium is often reversible, but it has to first be identified, then investigated and treated appropriately, as they have to address the underlying medical problem that is bringing about the symptoms of delirium. Now, a person can go to the hospital because they are experiencing symptoms of delirium, right? This is kind of the situation I just described, but they can also acquire delirium while in the hospital. If a person is going to develop delirium while at the hospital, it's typically going to be within the first 48 to 72 hours. That's when they are at the highest risk. Now, it's not to say that they can't develop delirium after this period of time. This is just when it's most likely to occur, okay? And there are actually several risk factors for developing delirium. So let me just list off a big chunk real quick. So being over the age of 65, having a cognitive impairment and or dementia, having a hip fracture or undergoing a surgery, having an infection or a serious illness, polypharmacy, meaning that they're on multiple medications, or if the person is on any medication that may have psychoactive side effects, like sedative hypnotics such as benzodiazepines or opiates, or medications with anticholinergic side effects, dehydration and poor nutrition, abnormal levels of sodium and potassium, out of whack blood sugar levels, poor sleep quality or insomnia, sensory deprivation, lack of mobility, whether it's due to weakness, restraints, or catheters, and then indwelling catheters on their own can also be a risk, and then mechanical ventilation. All of these things put a person at higher risk for developing delirium. With that being said, it's believed that about 50% of delirium cases may be preventable. If you think back through all the things that I just listed, many of them are within the control of somebody or something. But the problem is that delirium is often missed or misdiagnosed as dementia or a psychiatric disorder while people are in the hospital. So the symptoms are kind of blown off, or medical staff are quick to want to put someone in the behavioral health unit of a hospital without further investigating the symptoms. And then, two, unfortunately, much of the time, emergency personnel will be unaware that your partner has dementia. And even if they are aware, they often have limited training in dementia. And then, on top of that, many hospitals don't have great protocols to identify or address delirium. This is a huge problem because delirium increases the risk of longer hospital stays, which just isn't good for people with dementia, morbidity, further cognitive decline, the need for institutional care like long term care, and even death. So, even though delirium can be reversible, especially if it's identified in a timely manner and treated appropriately, about 25% of people will still have symptoms up to 3 months later, and about 20% of people will unfortunately never recover. They will never return back to their previous baseline, okay? So, what I want to do is talk about what we can do as the caregiver in efforts to prevent delirium from occurring while our partner is at the hospital, and what we can do if our partner is already delirious, because maybe that's why they went to the hospital in the first place. And the recommendations pretty much cross over, so just keep that in mind, okay? So, if I had to define your role as a caregiver when it comes to hospitalizations, it's going to be the prepare and the advocate. And if I'm being honest, it can feel pretty intense. I know sometimes caregivers want to use hospitalizations as a break, which I completely understand. But when a person has dementia, it's super important that you try to be as present as you have the bandwidth to be, both during their time at the ER and once they are admitted, especially for the first 3 days if they are kept that long. Now, in the treehouse, we are going to talk more about packing hospital bags and important documents to have on hand and that type of stuff. So, if you haven't joined the waitlist and you're interested in learning more, I'll have the link in the podcast notes. But for this episode, I want to highlight two things that you should make sure to bring, and they are both something that you may not think of. So, for one, you want to bring a customized document. So you may want to go grab a pen real quick and write this down because I'm going to tell you what this customized document should have. So the document should have a recent picture of your partner living with dementia, especially if they are at risk for wandering. Then you want to put things that are going to be good for the staff to know. One is that you make sure they know that your person has dementia. If you know the specific type of dementia, you want to be sure to specify that, and any other medical conditions that you want to make sure that they are absolutely aware of, like diabetes and the need for insulin, or chronic kidney disease and any fluid restrictions that they may have, things like that. Then write down their normal baseline, so how they were functioning before they got sick or injured. Now, don't get too lengthy with it. Sum it up and keep it concise, okay? But be sure to put any adaptive equipment they typically use, and if they wear eyeglasses, contacts, hearing aids, or dentures. Then put the name that they preferred to be called. Maybe it's Dr. Brown, maybe it's Bubba, maybe it's Mr. Charles, maybe it's Boss. Then put 3 tips for how to best communicate with the person. This could be to talk slow and clearly, to keep sentences short and simple, And make sure you talk to them at eye level, whatever you think would help. And then put 3 tips for how they can calm the person if they get agitated. Next, you want to write down any triggers and dislikes, so topics to avoid, behaviors to avoid, triggering objects, things like that. And then write down any likes that they have or things that they connect with that can help the staff build rapport. It can be interest, topics, familiar names of their friends or family, pets, food, anything. And then write down their typical routine, including the times they typically eat, shower, take medications, use the bathroom, and sleep, and then any important religious or cultural considerations. And if you have any tips for any of these areas, you can briefly outline those too, okay? And then lastly, you want to put your contact information so they know exactly who they can call and reach out to if they have questions. These are the kind of things that you want to make sure that you have on that sheet. And you want to print out multiple copies and be ready to hand them out to every person who comes in contact with your partner. Because unfortunately, people suck at communicating. So you cannot assume that anyone is going to pass along the information or review the information in the chart, because unfortunately, it just doesn't always happen. Now, if you join the treehouse, once we launch, there will be a sheet for you to download, fill out, and print. But if not, I'm going to link a document called This Is Me by the Alzheimer's Society that you may find helpful if you don't want to create your own or download Bambu Care's version from the treehouse. So that's number 1. Number 2 is that you want to bring a few familiar items. Even if you don't know if the person is going to be admitted, it's best to just go ahead and bring them. And honestly, it may help with the waiting room experience as well. Now, you want these items to be things that are going to bring comfort. So, for someone, this could be a religious book, a playlist of their favorite songs, a comforting blanket or pillow, and pictures of their family. And then it's also usually better to bring their own toiletries and clothes from home. Now, the hospital usually has their own lotions and toothpaste and toothbrushes and combs, but a person with dementia may refuse to use these items if they do not recognize them as their own. So it's usually best to just have their own items ready to go, okay? Now, some hospitals do have restrictions on what personal items can be brought into the hospital or into their room. So, if there's a go-to ER or hospital that your partner would most likely go to, you may want to call and ask just so you can plan ahead in the event that your partner needs to go to the hospital, okay? So, this is what I would consider part of the preparation role. Next is the advocate role. Now, once upon a time, a caregiver said to me, "People tell me all the time to advocate, but how am I supposed to advocate when I don't know what I'm supposed to be advocating for?" And she's absolutely right. We hear advocate, advocate, advocate all the time. But what does that really mean? What does that look like? What are we advocating for? So, I think the best way to approach this is to educate you all on a few things and then emphasize the things that you, as the advocate, want to try and make sure that you do or other people do, okay? Now, let me get this out of the way first. One problem that you may run into is the hospital not allowing you to go back with the person with dementia due to their visitation policy. So, the best advice that I can give you is to not accept this. You want to say something like, respectfully, "Bob has a disability, he has dementia, and I am his support person. I am not a visitor. Bob having a supporter is a reasonable accommodation which is required under the ADA, and I will be accommodating Bob." Period. Okay? And then having proof of the person's diagnosis and any like health proxy or medical power of attorney or guardianship paperwork can also be helpful in supporting your statement. But whatever you do, please do not emphasize your relationship to the person, like that you are their spouse or child, because most don't care, okay? That would just put you into the category of visitor. You want to emphasize that you are their support person and that you fall under your partner's right to reasonable accommodation so that they can fully access proper care, okay? So hopefully that helps, okay? Now, back to delirium. So, one of the things that can really make the symptoms of delirium worse when it comes to hospitals is that it's a very unfamiliar environment, which can be confusing. It can be very noisy with lots going on, so sounds, people, equipment, and it can disrupt a person's normal routine. So, when we think of confusion, when we think of agitation, hospitals are the perfect recipe for quote unquote disaster. So, we want to keep as much familiarity and routine as possible, even while they are in the hospital. This is why having that document that we talked about is important so that everyone can be on the same page. And if possible, it should be encouraged that the routine is stuck to. So, open up the blinds during the day to let some light in. Just make sure that it's not blinding anybody. And make sure that they are wearing any eyeglasses, hearing aids, dentures, if that's what they would be typically wearing at home, and if it's possible and safe to get them on or in while they are at the hospital. Having a clock from home that they can read and interpret, and a whiteboard with a kind, reoriented message can also be helpful so that your partner has some context to what's going on. Now, of course, this strategy wouldn't be helpful for everyone because some people with dementia can no longer read or interpret a clock, and sometimes they can't read your message on a whiteboard. But if your partner can read and interpret things like clocks and messages, it may be a very helpful strategy. Also, if relevant, ask if the staff can put any monitors or machines on the lowest sound setting that's safe for it to be on so that there is no unnecessary or annoying beeping or whatever sound that the device makes. Now, it may be tempting for you to turn the TV on in the room, but I strongly recommend that you only turn it on if the person requests for the TV or you ask about the TV and they say yes, because it can often be just too much with everything else going on and it can end up overstimulating your partner. Also, while it's understandable that some people may be tempted to visit your partner now that they're in the hospital, my recommendation is to limit visitors. Even if the hospital doesn't have a strict visitation policy, I recommend that you create a strict visitation policy. People should not just be popping up at the hospital to visit unless you are certain that the presence of a particular visitor would genuinely bring your partner a sense of calmness and joy. But also keep in mind that if your partner is experiencing delirium, they may not remember you and they may not remember this person who is wanting to come. This might not be permanent, but while they are experiencing their symptoms, they may just not be able to recall who you are in the timeline that they're currently in, if that makes sense. So you want to be very selective about who you allow to visit, okay? You want to minimize potential disruptions. Also, if doctors or nurses want to bring in medical students and you think that having too many people in the room would be just too much for your partner, it's okay to speak up and say that you do not consent for a med student to observe. All you have to do is say something like, respectfully, in the best interest of Bob, we would like to decline consent for observation by a medical student during his medical care. Now, if you haven't noticed, respectfully is my go-to phrase. That and, there's really no easy way to say this, and then I just say what I need to say. Now, because you all will be in a hospital setting, it's not uncommon for medical personnel to be in a rush, to talk too quickly, ask too many questions, or just generally not know how to best communicate with someone living with dementia. So you may see baby talking, for example, or them prioritizing reality orientation over validating. And so, again, the sheet where you outline communication recommendations can be incredibly helpful. And we at Bamboo Care also have what I call dementia care cards that you can hand out to people. These cards quickly outline 3 ways to facilitate better communication with the person who has dementia. You can find them at letsbamboo.com/shop if you're interested. They are really good for any situation in which other people will be interacting with your partner living with dementia, and you'll see it called the Dignity Duo on the website, okay? Now, because people with delirium are more prone to delusions, and most people in general don't like hospitals, it's not uncommon for people with dementia to develop the delusion that the hospital staff are trying to harm them. This is a delusion that makes a lot of sense, right? So, my best recommendation is that both you and the care staff or hospital staff explain everything that you are about to do before you do it in a short, simple way, even if the person is nonverbal or non-responsive. Be gentle, be patient, and respect no's to the best of your ability. Also, if your partner expresses that the staff is trying to hurt them, please, whatever you do, do not say, "No, they're not. They are just trying to help." I can almost guarantee that response is not going to go well. Instead, you want to validate the emotions that your partner is expressing, and then ask them a question like, "Well, what are they doing that you don't like?" This will give you a better idea if there may be something specific that a nurse or someone is doing that your partner doesn't like or may be misinterpreting. And if they do tell you, you can just say something like, "Okay, well, thank you for telling me. I'm so sorry that happened. I'll be here with you to make sure that you are safe and that no one hurts you." And comfort them that way. And then, if you can, distract to something else that's more pleasant. Because inattention is usually a big part of delirium, distraction after validation is often an effective way to shift your partner's mind from whatever they were so worked up about. But please, whatever you do, do not deny what they are experiencing. Just don't do it. Trust me, okay? Now, let's go back to talking about routine. If your partner has a typical time that they usually take a shower, I highly recommend that staff or even you try to stick with that schedule, whether they are able to take a full shower or if it has to be something like a bed bath. If it is a bed bath, please remember just how cold someone can get when they are wet and in the open. And sometimes hospitals are so freaking cold, right? So if the staff doesn't seem adequately prepared with enough towels or coverings to keep them warm, it's best to speak up before the bath starts. Now, I know that no one likes to be told how to do their job. I'm one of them, but it's not about us. It's not about them. It's about the person we are caring for and what would be in their best interest in these types of situations. Nobody wants to be cold, naked, and vulnerable. Anybody would become combative in this type of situation or withdraw and refuse to cooperate. Now, as far as activities, if you are alert in the hospital, you know just how incredibly boring it can be to do absolutely nothing in a hospital room. This is true for a person with dementia as well, and this can make them super restless. And if they're able, they may try to get up and out of bed because they want to move around. The body is craving movement, the body is craving to do something. Now, because they are often a fall risk or unsafe to move, staff will often want them to stay put. But if possible, we really want to advocate for mobility. So, if a physical therapist has not been called in to do an evaluation, I highly recommend that you ask if this is a possibility, and then ask the physical therapist what would be the safest way for them to get movement while they are at the hospital. They should be able to give you recommendations based on their assessment. Also, if your partner is experiencing symptoms of delirium and you think the environment is a big trigger to their symptoms or exacerbating their symptoms, I'd recommend also requesting an occupational therapist if one hasn't already been requested, simply due to your partner's change in their functional status. They can assess the environment and give recommendations that can improve your partner's symptoms, and they can also give you ideas for therapeutic activities that you can do with your partner during their hospital stay. You can also bring your own activities from home, which I recommend, that you think your partner would enjoy, like a puzzle, a simple board game, large print playing cards, or a photo album, even some knitting stuff if that's something that they like to do. You can also play football with sugar packets. You can look at animal or nature videos on a tablet. The point is, make sure that you have a few ideas up your sleeve to keep your partner entertained during their stay, especially if they are awake and alert, and then see what the staff can come up with to encourage mobility. Now, if your partner is in a state where they cannot move on their own, maybe even they are unresponsive, ask about early mobilization strategies that you can do with your partner while they are still in bed, and make sure that the staff is repositioning them every 2 hours or teaching you how you can reposition your partner safely on your own every 2 hours. This is so important because you want to prevent further complications such as decreased circulation and bed sores, okay? So this is something that you can ask the nurse, the PT, the OT, whoever you can get a hold of, okay? Now, at night, you want to make sure that you close the blinds. Also, many hospital rooms are equipped with dimmable lighting, so consider adjusting the lights to a softer level once it turns nighttime. And be sure to relocate any objects, if safely possible, that might be casting unsettling shadows in the room. And this becomes particularly important if your partner is susceptible to or currently experiencing hallucinations or illusions, such as mistaking a shadow for a person or animal. And if your partner is open and willing, earplugs may be a way to help them get better sleep once they are ready for bed if the hospital environment is still particularly noisy at night. Just know that if the staff comes in the middle of the night to wake them up, they have to be mindful of how they wake them up, like touching the bigger joints like the knee, the hip, or the shoulder with deep pressure while calling their name until they open their eyes. Or you may even want to be the one to wake them up so that they can see a familiar face when they first open their eyes. We don't want to startle them, okay? Now, since this episode is already getting a little long, I want to lastly mention medications and what should be considered last resorts. So, in the beginning of this episode, I mentioned that medications that have psychoactive side effects, like sedative hypnotics such as benzodiazepines, or opiates, or medications with anticholinergic side effects, were a risk factor for delirium. So, you want to be sure to ask for a medication review to see if your partner is currently taking any medications that would fall into these categories. And then if the doctor recommends any new medications, you also want to ask if those medications fall into any of those categories. If they do, you want to ask if there is a safer alternative for whatever the purpose intended is that has a lower risk of causing your partner confusion and cognitive decline. Because unfortunately, the number one cause of hospital-acquired delirium is often considered to be medications. And if the person already has delirium, they can make the symptoms worse. Now, you would think that the nurses and doctors would take a look at these types of things on their own, but sometimes they don't. And that's why it's important that you know so that you can advocate, okay? And then the last resorts are antipsychotics and restraints. One thing that we must understand is that any behavior, even if it's aggressive or violent, is a form of communication. So if we can figure out the trigger and unmet need, what our partner is trying to communicate, the behavior can often be addressed without medications. But it is true that in some cases, especially if alternatives have been exhausted and the person has become a danger to themselves or others, that antipsychotics or even restraints may be necessary. But please do not just allow them to restrain your partner or put them on antipsychotics for just any old reason. And also, if your partner has Lewy body dementia or Parkinson's disease, you want to make sure that the medical team knows that information because typical antipsychotics, like Haldol or haloperidol, you may hear it referred to as, are typically poorly tolerated by people with these types of conditions, and it can actually worsen their symptoms or even cause death. So, again, on that sheet that we talked about, make sure that you put that and let them know as well as verbally tell them if necessary. Okay? So, I think that's where I will leave it for this podcast episode. I know it's kind of an abrupt stop, but like I said, the topic of hospital stays is such a dense topic, and we really only scratched the surface. But I really do hope that what I was able to share in this episode was helpful and informative. Again, if you find our podcast helpful, please consider leaving us a review to help others find the podcast. If anyone has any questions, comments, or future podcast requests, remember you can send us an email at podcast@whatthedementia.com. Thank you so much for joining us on another episode of What the Dementia by Bambu Care. We look forward to catching you on the next episode. Take care, and until next time, stay strong, care on, and remember, you are not alone. Bambu Care is always here.